Primary care or GPs are the front door to accessing health and care services. More than 80% of the consultations happen in primary care. So it's very crucial that the GPs are trained and understand what this individual is there in front of us for. Is it just the presenting problem they're coming in with? For example, if someone comes in saying that I'm anxious about something, is it just the anxiety that they are worried about? Or is there an underlying neurodivergence? Or are there underlying neurodivergent conditions that this person may be presenting with?
We do think that autism's underdiagnosed in older people in the UK. So we do see, looking at general practice data, we do see much higher rates of diagnoses in children and younger people compared to older people. And this is despite the fact that research that has surveyed the UK population to look at the true rate of autism across different age groups has actually found similar numbers of autistic people across different age groups. So what we think is that the higher rate of diagnoses in children and young people is reflecting better awareness of autism, better access to diagnostic assessments, and also recent broadening of diagnostic criteria. So when we look at the proportion of people in different age groups who have a diagnosis, we find that around 1 in 35 10 to 14-year-olds had a diagnosis as of 2018, compared to about 1 in 1,400 people aged 50 plus. So we also see that more than 80% of new diagnoses made in 2018 were in people aged under 18. So it seems that there are huge age-related inequalities in access to diagnoses in the UK. And we estimate that at least 9 out of 10, possibly as many as 19 out of 20 over 50s who are autistic are undiagnosed.
Yeah, I'm going to be talking about the issue of GPs often being the very first person that a concerned parent or an adult who has concerns about their own kind of difficulties, that GPs are often the first person they speak to, and they can play a vital role in ensuring that appropriate referrals are made on to specialist teams if necessary. It appears that a lot of the understanding around autism amongst some medical professionals is that it's very much the stereotypical male view of, lack of eye contact, poor play, and the sort of not being able to maintain a conversation. And many people have talked about masking and camouflaging, and I'd like to talk particularly about the case for girls and often non-binary people and some young men as well, who don't present in this stereotypical autistic way. Their eye contact will often be very good. They will often be able to maintain a conversation. They will be able to appear as apparently neurotypical. It's only when you actually listen to what they've got to say that you realise that there are significant difficulties, and the challenge to them is actually maintaining that and keeping that kind of picture up, if you like.
My first reaction when I was told I'm autistic was a sense of relief, and I cried. I found it really hard, not because I didn't want to be autistic, but because I wasn't expecting it. It was something that I'd thought about for a long time, whether or not I am autistic. And it was that sort of an overwhelm of lots of different emotions, and really sort of having to start thinking, who am I?
It's important to think about autism and physical health conditions because there is an emerging body of work that suggests that autistic people are not only more likely to experience physical health conditions, but also to experience significant barriers to accessing healthcare, which could result in adverse outcomes. So if you are working or treating or managing an autistic person, it is really important to think about both things that are happening in the body and things that are happening in the brain and in the mind, because there's a sort of false distinction between brain and body that means that sometimes problems can be overshadowed or overlooked. And it's really important to think about both together to maximise health and well-being for all people, but including autistic people.
Trauma, PTSD and complex PTSD are very common in autistic people, and they seem to have a role in suicidality. So we know that autistic people are much more likely throughout life to be victimised, to be bullied, to be assaulted. And we also know that adverse childhood experiences, which are very much associated with mental health and suicidality in adulthood, are much higher in autistic people. And the symptoms of trauma don't look quite the same in autistic adults. So it's often harder for them to get diagnosed with PTSD and to receive support.
So what do we say to them when they present with something they are anxious about? Do we say to them, oh, most of us do experience the same thing and it is normal? I think we should avoid saying that. And what we need to say is that I can see that this has been really worrying you, that you had come to see me as a concern, and let's gather some more information to address these concerns.
Okay, so because I can talk and have a two-way conversation, it's almost always assumed that I am able to cope with life in a normal way, and people assume that I am high functioning, but I think GPs especially need to realise, if they look at patients' history of missing appointments, attending appointments, you know, and look and think about why is this person not able to get into the surgery? Is it because they can't cope? And, you know, we should stop assuming that just because they can have a two-way conversation that they are coping and managing in the world, because they might not be.
I think a really, really important point to remember fundamentally, and it's key to understanding the whole autistic experience and improving things for autistic people, is the neurodiversity paradigm, which is the idea that there are a whole range of different neurotypes, essentially, which is type of brain and how your brain and neurological system function. Autistic is one type. We have ADHD, we have Tourette's. These are all what's referred to as neurodivergent conditions, which is where the way the brain and its systems function diverges from what is the most commonly observed or the most frequently encountered neurotype. And so we refer to that as neurotypical, or what you would call normal, if you like. So anything that diverges from the typical, most common neurotype would be considered neurodivergent, and those are your neurodevelopmental conditions, so your autism, ADHD, etc., etc. And with that, it's important to consider disability in terms of the social model of disability rather than medical model. So disability is not an internal thing. It's not something you are disabled because there's something faulty or wrong that either needs fixing or accommodating for. It's that the world around you, society, and everything about the environments we live in has been structured and built based upon the needs and preferences of neurotypical people, because that is the most common way of being. It's the most common neurotype, so neurotypical or normal. And so when we start to think of autistic and neurodivergent traits or diagnoses as differences rather than deficits, and realise that an autistic person is not a broken neurotypical person. They're an autistic person who has just as much potential, worth, capability, understanding, purpose as a non-autistic person. Then we start to see things in a slightly different light. So yeah, difference, not deficit, is really, really key to understanding the whole autistic experience.
In order to get a diagnosis of autism, you have to meet the criteria, and one of the criteria is that you will have social communication difficulties or differences. That's a given. So if a person arrives at a GP surgery who has a diagnosis of autism or who self-identifies, they will have social communication difficulties. That's it. That's how it is. So if they come across as maybe aggressive or stressed, and they might even swear when they're stressed because, you know, they might have been sitting in the waiting room and they might have built up this anxiety about coming in, and it might have even taken them weeks to get through the door, and then they do a big brain dump and it seems overwhelming. That's because they've got communication difficulties. It's not because they are aggressive or they're being, they're trying to be kind of horrible in any way. It's just how it is, and you can't control that as an autistic person. If you're stressed, it's part of the condition, and no matter what you do, your communication is going to let you down sometimes. And I'm quite a good communicator, but when I'm really stressed, that all goes out the window and the filter's gone, and everything just comes out, and it's really upsetting for me and other autistic people, because you know that you may be coming across as angry or aggressive or not a very nice person, but it is just the stress that does that.
So we don't really know for sure, and there might be several different factors involved. So one is that it seems like the onus is often on the individual to self-identify that they might be autistic and seek a diagnosis. So one person said to us, essentially, you have to know that you're autistic to be diagnosed. And obviously there must be a lot of people out there who haven't self-identified as being autistic, who therefore wouldn't necessarily know that they're autistic. And it's not necessarily something that primary care providers might have had the training to be able to spot, or indeed might not know the person well enough to be able to spot. Among those people who do self-identify as being autistic, there seems to be variable receptivity among primary care providers towards referring them for a diagnostic assessment. There's a lack of services leading to very long wait times, so waiting lists of longer than 2 years are common. And if they end up in mental health services, so historically, they've also been less aware of autism. So this has led to, for example, misdiagnoses of personality disorder. From the perspective of primary care providers, there might seem to be a kind of lack of impetus for a diagnosis in older people. There might be the perception that not much would change for that person if they were to have a diagnosis, but in fact, often that's not the case. So having an explanation for why someone might have struggled socially throughout their lives can have a really profound impact on that person psychologically. And also it's a means by which someone can advocate for themselves. So for example, if their behaviour is misinterpreted, they can advocate for themselves and explain that they're autistic. Sometimes they do things differently to other people. And they might need adjustments to change how services routinely operate to allow them to engage.
Possibly the most important thing to think about when thinking about the label of emotionally unstable personality disorder is the huge stigma that is attached to it and the way in which it undoubtedly influences the way that medical and other professionals will interact with that person going forward. And it can be a case where the autistic person's personality is completely missed, and all that is seen is this kind of attention-seeking or difficult behaviour.
Late diagnosis can also be a risk factor for poorer mental health and possibly suicide in autistic people. A number of studies are showing us that when autistic people are diagnosed late in life, i.e. not as children, they're more likely to experience a lot of invalidation and a lot of bullying, a lot of victimization from the world. They often grow up with very negative narratives about themselves, for instance, as broken, bad, stupid, weird, that it's their fault for a lot of the bad things that have happened to them in life. And a lot of people after diagnosis never receive any post-diagnosis support in order to unpack some of these things. Finally, it's worth mentioning self-injury as a potential risk factor for suicidality in autistic people. There's a lot to say here, a lot to unpack. It's a very complex topic, and it's possible that not all self-injury is a risk factor for suicidality, but some studies do indicate that engaging in self-injury is a risk factor for later suicide.
I think there's a whole number of reasons why girls are misdiagnosed, but I think one of the main things is if we just think about the diagnostic tools, the diagnostic tools are primarily geared around males, and for so long we didn't think that women and girls could be autistic, and so it's been a real stumbling block for many women in getting a diagnosis. But I think there's some other reasons in terms of how girls present. So girls do present as being a lot more socially able than boys, and they do that all through primary school. They appear to be a lot more socially able. They learn how to copy and mimic, and they learn certain phrases that they might have seen on the television or other girls are using, and they use those in the playground or with peer groups. But they're also starting to mask. So as early as 4 years of age, children may be masking. And when I've talked to many of my clients about this, they've said, yes, they didn't know it was masking, but they knew they were doing something that meant that they fitted in. And I think girls try really hard to fit in, to be the same as, not to stand out. So they may have the same interests as many of the other girls in their peer group, but actually when you talk to those girls, it might be something like My Little Pony, and some girls may only have 2 or 3, but many autistic girls will have about 30 or 40 of whatever their collection is, and they become quite obsessional about what they like and what they're doing. And sometimes we don't ask those questions. We just make the assumption that they're the same as everybody else. One of the other things that I've noticed about clients that I've worked with is that they have a really creative imagination. So girls are able to kind of drift off into an inner world that they find is very safe. And they use that as a way of masking and protecting themselves when they're really struggling with high levels of anxiety. But they don't talk about that, but they may just look as though they're zoning out or not really paying attention, but they're often in their creative worlds.
One thing I would say to GPs is if you ever experience somebody having a meltdown, understand that it's not a tantrum. It's not because they can't get their own way. It is simply because they've become so overwhelmed with anxiety and fear and whatever it is, frustration, that they've reached the point where they've become saturated. And sometimes it can appear threatening, but it's rarely threatening. What it is about wanting to escape the situation. It's more of a flight response than anything else. And if you're ever in those situations, it, like I say, it may look frightening, but just take that step back and give the person the time to reset. Maybe ask them if maybe put them into another room or something like that where they can reset. But it's always good to understand that they're not going to, very rarely are they going to be violent. It just doesn't happen. They're more likely to run away.
Thinking about how this can be avoided, I think the first thing to appreciate is the impact that this has on the person and how important it might be for them to have that label either removed or clarified when and if an autism diagnosis is subsequently added to their records in this particular presentation. Basically, it is possible to have features of distress behaviour and be autistic, but the reasons behind the behaviour need to be considered, and the impact of years of being misunderstood and your behaviour being misinterpreted can't be minimised. So it is very important to emphasise that the person is actually autistic and that this is not a stigmatising behaviour, or is not something that needs to be used against that person in future.
There's a lot of comfort and strength to be had in the relationship between you and the patient. Remember the importance of social connection, of that person feeling valued as they are, not having to hide, not having to camouflage. You are doing them a great service by listening non-judgmentally and compassionately.
Autistic people who have a diagnosis have extra support needs, and we think that this is also likely to be the case for autistic people who aren't diagnosed. And so it's concerning that so many people are undiagnosed in the UK. Having a diagnosis is important even for autistic people who live independently and are employed. And this is because autistic people often show strengths in some areas but challenges in others. So, for example, some are vulnerable to being victimised or exploited, and sometimes they might, their behaviour might be misperceived or misunderstood, and they might also need adjustments in the workplace or in order to access care and support that they need. So often someone might seem to be coping well, so people might also fail to recognise that actually family members are supporting them behind the scenes. And this works perhaps with someone with more support needs whilst their families are able to help. But having a diagnosis means that local authority services can support the person if they get into difficulties. And this means they're less likely to be left to handle a difficult situation without that extra support.
It seems curious sometimes to think about the link between autism and physical health conditions, but we know from work that we've been doing here at Brighton and Sussex Medical School that there's actually a link between neurodevelopmental conditions like autism, ADHD, Tourette syndrome, and a common physical variant called hypermobility. And while some people think that hypermobility is an advantage, and it can be in gymnastics and music and things like that, there are also, because connective tissue is throughout the body, there are physical health concerns associated with hypermobility. So things like gastrointestinal dysfunction, cardiovascular autonomic dysfunction, asthma, allergies, things like this. And what we've been looking at here at Brighton and Sussex Medical School is how common hypermobility is in people with neurodevelopmental conditions. So in the general population, 1 in 5 people may have hypermobile joints. In our study, we found that in autistic, ADHD and Tourette syndrome, that over 50% of people with neurodevelopmental conditions were in fact hypermobile. And not only were they more likely to be hypermobile, the people with neurodevelopmental conditions were more likely to have physical health concerns. And these physical health concerns were things like pain and musculoskeletal symptoms, and also symptoms of dysautonomia, so things like dizziness on standing. So not only were the patients with neurodevelopmental conditions more likely to have physical health concerns than our comparison group, what we showed was that this relationship between neurodevelopmental conditions and physical health concerns was in fact explained in a mathematical model by hypermobility. So it's really important to think about these things together in order to make sure that you're recognizing things that could be treated or managed or supported in patients.
I actually, it's taken me a while to get to this place, but I am thankful I'm autistic. It's not about having a label. I'm thankful I am who I am. I can see all the different parts of me, my creativity, my brilliance, and I'm allowed to be different. I can be who I am. I'm embracing the fun parts of me. I really understand other autistic people. As a psychotherapist, I primarily work with autistic people who've struggled, who've not been seen through their lives, lots with a late diagnosis. And it's something to be celebrated. I don't see being autistic as a bunch of deficits as described in the Diagnostic and Statistical Manual 5. Actually, I'm different. We're all different, and it's really, really okay to be different. There are times when I have struggles and shutdowns, meltdowns, and there are times when I can sort of be there and just enjoy being who I am.
Things start to present more overtly for girls when they're adolescents. And I want to tell you the story of my daughter, but the story of my daughter could be the story of any woman that I've worked with in my psychotherapy practice. So her transitioning to secondary school was a really difficult one. Big school, lots of people, lots of noise. Didn't really know very many people, had come from a primary school where she had some friends, but not a lot of friends. The first year, she really struggled to make friends. And what became much more apparent was that as she became more adolescent, the rules of social communication started to change. And she really struggled to keep up. She struggled to keep up with some of the interests that some of the other girls had. She struggled to keep up with just exactly what was being said in the conversation. Conversations were much faster in pace. But coupled with that was puberty and hormones, which made it incredibly difficult in terms of sometimes managing what was happening and her level of anxiety. And what happened for her is the same for many of the women I work with, which is that she started to find school incredibly difficult. She wasn't wanting to go. She was refusing to go. Very high levels of anxiety, very low mood, and had some ideas of wanting to harm herself. So we went to see the GP, and the GP then referred us to the Child and Adolescent Mental Health Service. And she was seen. So I'm talking now about 12 years ago when she was seen, when we were still really trying to understand girls who might be autistic, seen by a psychiatrist who said, well, you couldn't possibly be autistic, which is what we'd gone to find out, as we have other members of the family who are autistic. You can't be autistic because you've got friends and because you have eye contact and you seem very happy. And that was almost the seal of doom, because from that, and nobody listening and hearing her and understanding what was going on for her, she refused then to go into school and was diagnosed, if there is such a diagnosis, of school refusal. Once she came out of school, it was very apparent her anxiety was very high, her mood became very low, and she often had some suicidal ideation. And off we went back to the GP, back to CAMS, but nobody was listening to her. Nobody was listening to me as her advocate, and she was dismissed because she didn't present in this stereotypical way. And that's just the story of my daughter, but that story is so familiar to me with so many people I work with who have been diagnosed with eating disorders, anxiety, depression, obsessive compulsive disorder, all the things that were visible, but what was never looked at was what was underneath all of that. Why were these people presenting in this way? And actually why, with some interventions and perhaps some medication, nothing really changed. They just continued in some cases to get worse. And for many, coming out of education really affected how their lives were then determined.
It's really important that doctors take a lifespan approach to working with autistic people, aware of all these reproductive transition points which are going to have massive hormonal impacts on the way they function. And remember that these are not only going to be difficult for that person, they're going to change the way they experience their autism. So autism and these reproductive transition points seem to amplify one another. So just be aware when you're working with autistic people of their age and of these transition points as they're coming along within the lifespan. And prepare your patients as well. Before these points happen, it may be worth discussing them with the patient, possibly inviting them to bring advocates along, just helping them have some understanding of what to expect, that this time of life might be challenging, there might be some changes and what those might be. So have these discussions, if you can, before someone enters perimenopause, just so they have that awareness about what might happen, and so they're not taken completely off guard, so that they know what these changes are if this happens to them. There's a very good healthcare toolkit that doctors can access called the Aspire Healthcare Toolkit, and it contains a lot of materials and tools around having conversations with your patients. Although it's not menopause focused, there's a lot about helping your patient to identify changes in their body so that you can have a productive consultation with them. There's another toolkit called Know Your Normal, which might be very helpful as well. So this really helps people get a sense of what does my body normally feel like? What's my sleeping normally like? And so forth. So that when changes happen, they're more able to tell you about them.
Take home message, I think, is think body and brain. Do not think, this people can't experience pain because they're autistic. Don't let one thing overshadow another. People live in brains and bodies and things interact. If you see someone who is hypermobile, think about physical health problems, think about anxiety, think about the possibility of neurodevelopmental conditions. If you're seeing an autistic person or a person with ADHD or other neurodevelopmental features, think physical health concerns, think hypermobility, but really importantly, think how can we make healthcare as accessible as possible for all, including autistic people.
I wanted to talk about the experience of my autistic son. My autistic son died at age 35 from undiagnosed pneumonia. And I would like his case really to be a learning experience for those medical professionals working with autistic people. He was not stereotypically or obviously autistic. He was one of these that masked his difficulties very well. However, when he was anxious, he was very often mute and unable to express himself very clearly. He was also highly anxious, and if he had a concern or a worry, whether that be medical or any other kind of worry, he would make multiple phone calls. He would repeatedly ring the surgery. He would make multiple visits to the doctors with his concerns. As a result, I think he became seen as a bit of a nuisance and someone to be got rid of as quickly as possible. And even though he was had mental capacity, he did not have a learning difficulty, there were times when he would have benefited from having an advocate or someone there in the surgery to speak for him. His partner accompanied him to the surgery when he got his late diagnosis and handed over his report to the medical receptionist. Sadly, this report was not flagged up on his medical records, so it was not the first thing that any new GP seeing him would have seen. So when he went into the surgery on this final occasion, because of his difficulties explaining how he felt, how his pain felt to him, he presumably, we don't know, didn't describe how his pain from his pneumonia was feeling. And this was at a time when pneumonia was rife in the area where he lived. So it was in the community, and there were lots of people who had this at the time. Unfortunately, it seems that the doctor that saw him missed this completely. So my son was diagnosed painkillers for his back pain, and sadly went home, took some of these painkillers and died overnight. He never regained consciousness. And this is a simple case of an autistic person who lost their life because the medical professionals that saw him did not take into account his autism. They did not take into account his difficulty explaining himself. They saw his repeated appointment making as him being difficult or awkward. They failed to understand that he may not always have taken on board what was told to him about the advice about how to take his painkillers. We'll never know. But I feel that had this information been flagged up on his medical records as the first thing that his GP saw when he came into the surgery, my son would still be with us now. And he left behind 2 small children and a partner. He was a talented musician. He was a bright, intelligent young man. And he lost his life basically because people did not understand that he was autistic.